Welcome to the Funnel Effect. We are diving deep today into what is arguably one of the most dynamic fields in interventional medicine right now. That's the state-of-the-art percutaneous interventions for pulmonary embolism, or PE, management. Our material today is really centered on a fantastic, comprehensive review that pulls together a lot of global experience and trial data. Now, I need to read the authors and sources for you. Bear with me. This is Simone Finocchiaro, MD, and colleagues. The article is titled State of the Art, and it was published in Eurointervention, Volume 20, pages E408 to E424 in 2024.
And our mission for this deep dive really is to try and map out where PE treatment is heading. And why is this so critical? Well, PE is a major health crisis. I mean, it's a leading cause of death for patients in hospital, and it's actually the third most common cause of cardiovascular death overall, just behind stroke and heart attacks. So we're constantly looking for strategies that aren't just effective, but crucially safer than the older traditional methods.
Exactly. And this source material really outlines the promise of these emerging percutaneous techniques. We're talking about things like catheter-directed thrombolysis, mechanical thrombectomy, and even hybrid approaches. The authors suggest this could be a potential paradigm shift toward what they call percutaneous primary pulmonary intervention.
Yeah.
Which sounds a bit like what happened with heart attacks, right? Finding an interventional way to fix the problem quickly.
Precisely. Well, trying to sidestep that really high risk of major bleeding that comes with the traditional systemic therapies.
Yeah. And to understand just how significant this shift could be, you really need to grasp the sheer scale of the problem.
Absolutely. PE is definitely not a rare condition. The estimates for annual incidence, they range somewhere between 39 and maybe 115 cases per 100,000 people globally. And what happens is this acute blockage in the pulmonary arteries puts immediate and sometimes fatal strain on the heart.
And the cost is just staggering, both in, euros and dollars, but also tragically in human lives. The article breaks down the economic burden, something like an estimated $3.8 billion annually in Europe.
And a huge $18.9 billion in the United States. That covers everything from the initial acute care right through to long-term management.
Wow.
And the human cost, as you said, is devastating. Around 350,000 patients die each year globally from PE. And something that often gets missed is the long-term impact. Up to 20% of patients diagnosed with PE actually die within that first year. And even for those who survive the initial event, there's this ongoing risk of long-term complications like chronic thromboembolic disease or even chronic thromboembolic pulmonary hypertension, CTPH.
Right, so it's not just about surviving the first few days.
Not at all. It really highlights why we can't just focus on short-term survival.
Right.
We need effective, definitive interventions that also address that long-term picture.
Okay, so that brings us squarely to the core clinical challenge then. How do you actually treat PE? The conventional approach seems to hinge entirely on risk stratification. Anticoagulation, blood thinners, that's the foundation, right? But when do you escalate?
That decision to escalate, yeah, it's absolutely crucial. And it really depends on two main things. First, what's the estimated mortality risk for this patient? And second, how stable are they hemodynamically right now? To put it simply, PE kills when that blockage causes the right ventricle, the RV of the heart, to fail because it just can't push blood against that sudden high pressure in the lungs.
Okay, so let's unpack that risk stratification a bit. Starting in the top, the highest risk patients.
Right. We call that high-risk PE. Sometimes you'll hear it called massive PE. And it's defined simply by hemodynamic instability. So the patient is in shock, their blood pressure is dangerously low. Now, this only accounts for maybe 5% of all PE cases, but the early mortality risk is just astronomical. We're talking around 50%.
50%, wow.
Yeah. These patients need immediate reperfusion. You don't have time to wait for anticoagulation to work slowly. You have to rapidly reduce that pressure load on the RV.
Okay, that's the critical group. But then you have the vast majority of cases, the stable patients. How do clinicians figure out the risk within that group?
So for the stable patients, we use standardized scoring systems, like the Pulmonary Embolism Severity Index, or PC score. Within that stable group, the really critical subgroup is the intermediate high risk, sometimes called submassive PE. Now, these patients are stable hemodynamically, but crucially, they show signs that their right ventricle is struggling.
Okay, what kind of signs are we looking for?
Specifically, they'll have high-risk PC scores, usually classes 3 to V. They'll have clear evidence of RV dysfunction on imaging, like an echo or a CT scan showing the RV is dilated or not squeezing properly. And very importantly, they'll have elevated cardiac biomarkers.
The biomarkers. Why are they so critical for predicting who might get into trouble?
Well, biomarkers like cardiac troponin and BNP or NT-proBNP, they act like little warning flags for heart muscle injury and strain. Troponin tells us the RD muscle itself is being damaged, likely due to the high strain and maybe reduced blood supply. And BNT tells us about the massive volume and pressure overload the RV is trying to cope with. When you see both of those elevated, along with that RV dysfunction on imaging, even though the patient looks stable, their chance of suddenly deteriorating hemodynamically is much, much higher.
Got it. And the standard treatment for this intermediate high-risk group is typically just anticoagulation, right? But this sounds like exactly where the debate about intervening earlier really heats up.
Precisely. They're stable now, but they're kind of like ticking time bombs. Standard practice is anticoagulation and close monitoring, with reperfusion therapy held in reserve only if they start to crash. But because that risk of crashing is significant, clinicians are really motivated to find safer, earlier options for reperfusion. And that's why so much focus in the percutaneous world is on this intermediate high-risk group.
Okay, let's talk about the oldest, maybe most powerful non-surgical option for reperfusion, systemic thrombolysis. Giving clot busters through an IV. It can clearly save lives in massive PE, but it comes with a pretty terrifying trade-off, doesn't it?
It does. It's actually the first-line treatment, a Class I recommendation for high-risk, unstable PE. And it works by flooding the entire system with these clot-busting drugs, which rapidly dissolves the clot, improves blood flow through the lungs, and takes that deadly strain off the RV. But the trade-off, as you say, is substantial. We're talking about a risk of major bleeding, including bleeding inside the brain, intracranial hemorrhage, reported in up to 10% of cases in some big trials.
10%. That's a huge complication rate, especially for something as catastrophic as a brain bleed. It sounds like this creates a real clinical paradox. It's indicated for the sickest patients, but maybe many don't actually get it.
That's absolutely right. It's a paradox often driven by fear, frankly. Even in patients with massive PE, clinicians often hesitate or withhold systemic thrombolysis. Why? Well, the patient might have other conditions, relative or absolute contraindications. Maybe they had a recent stroke or major surgery, or they have active bleeding somewhere else. In those cases, the perceived risk of causing a fatal bleed might seem to outweigh the benefit of dissolving the clot. This sometimes leads clinicians to try things like half-dose systemic thrombolysis, especially in those high-risk patients with relative contraindications. But that's often based more on clinical anxiety than solid trial evidence.
Okay, and the debate gets even sharper when you look at using systemic thrombolysis in those stable intermediate-risk patients. The PISO trial seems central here. What did that really show?
PITERA was a landmark trial, yes. A big randomized controlled study. It asked the question, if we give systemic thrombolysis to stable intermediate risk patients up front, does it improve their outcomes? And it showed that yes, systemic thrombolysis did reduce the rate of hemodynamic decompensation. Fewer patients crashed and needed rescue therapy later on. However, and this is the really critical point, that benefit was statistically wiped out by a significant increase in major bleeding, including, tragically, 3 fatal intracranial hemorrhages in the thrombolysis group.
Wow, so they avoided a crash, but had a higher chance of a fatal bleed. What was the net effect on survival?
Crucially, the trial showed absolutely no reduction in death from any cause at 7 days. And furthermore, looking longer term, there was no benefit in reducing residual shortness of breath or improving long-term RV function over 3 years compared to just anticoagulation. So this is the source of the ongoing controversy. Did the trial fail to show a mortality benefit because maybe the patients weren't quite high risk enough? Or was it because the severe bleeding risk truly canceled out any potential benefit? The current consensus, reflected in guidelines, is pretty conservative. Routine use of systemic thrombolysis in intermediate risk PE is generally not recommended. That's a Class 3 recommendation. It's really reserved only for rescue therapy if a patient starts deteriorating rapidly.
It really sounds like, despite the guidelines, clinical practice is often driven by that fear of a patient suddenly crashing, which pushes clinicians to aggressively look for alternatives that might give the therapeutic benefit without that massive bleeding risk.
That is absolutely the driving force behind this whole field of percutaneous intervention we're diving into today.
Okay, the final traditional reperfusion method is surgical embolectomy, opening the chest to remove the clot. What's its current role? It sounds quite specialized.
It is specialized. Surgical embolectomy is primarily reserved for those high-risk PE patients who either failed systemic thrombolysis, meaning the clot didn't dissolve, or who had absolute contraindications, meaning they couldn't receive John Bolex at all. It's highly invasive. It requires opening the chest through a median sternotomy, often going on cardiopulmonary bypass, so the heart-lung machine, while the surgeon physically removes the clots. This needs a dedicated, highly skilled cardiac surgical team, and that's just not available at every hospital, especially not 24/7.
But the source material notes that its use might be cautiously expanding, maybe even into some intermediate risk patients.
That's true. Over the years, surgical techniques have improved, and the historically very high mortality associated with the procedure has come down significantly, particularly in high-volume centers. This makes it a potential option now for some very select, intermediate, high-risk patients. These might be patients who have, say, a very large mobile clot seen floating in the right heart chambers, what we call thrombus in transit, which is a major risk factor for sudden death. Or maybe patients with a massive clot burden sitting right in the main pulmonary arteries where maybe systemic lytics might be too slow or deemed too risky. It definitely remains a specialized, high morbidity procedure, but it can offer survival rates comparable to thrombolysis when done by experienced teams.
Okay, so this tension, the need for rapid reperfusion versus the risk of catastrophic bleeding, perfectly sets the stage for why percutaneous interventions are seen as the future. This is the conceptual shift, right? Minimally invasive, catheter-based approaches doing the work locally.
Absolutely. The beauty of the percutaneous approach is that localization. Instead of a systemic effect, we're aiming for thrombus disruption, maybe fragmentation, or outright removal right there at the site of the blockage, all through a catheter inserted typically via a vein in the leg or neck. The goal is to target the clot while shielding the rest of the body from those systemic complications, especially bleeding.
And the data seems to strongly back up that SACE premise. You mentioned the 10% major bleeding rate with systemic lysis. How do these interventions compare?
They compare very favorably. If you pool the data across the various different percutaneous techniques that are available, the procedural success rate is high, around 87% generally. But the safety figures are what really capture attention. The overall risk of major bleeding or vascular injury is significantly lower, down around 4.65%. And crucially, the risk of that most feared complication, intracranial hemorrhage, plummets to just 0.35%. That is a dramatic improvement in safety.
And it sounds like the goal isn't always to get every last bit of clot out, but maybe just to stabilize the patient.
Precisely. Often, the primary goal is hemodynamic stabilization. We want to relieve enough of that pressure on the right ventricle, enough RV afterload reduction, to effectively downstage a high-risk PE patient into an intermediate risk one. This allows their own body's natural clot-dissolving mechanisms, along with anticoagulation, to take over and finish the job. Sometimes, being overly aggressive trying to achieve complete clot removal can actually lead to complications itself, like pushing fragments further down into smaller vessels or even damaging the pulmonary artery. So the focus is often on pragmatic flow restoration first.
Okay, but the complexity here, balancing the risk scores, looking at the imaging, deciding which specific device to use for which patient sounds immense. You'd need a really coordinated system for making these calls, wouldn't you?
You absolutely do. And this underscores the vital necessity of what are called pulmonary embolism response teams, or PERTs.
PERTs.
PERTs aren't just a nice to have anymore. They're increasingly considered essential infrastructure for any hospital dealing seriously with PE. They basically institutionalize that multidisciplinary collaboration. You have emergency docs, interventional cardiologists or radiologists, cardiac surgeons, pulmonologists, critical care specialists, pharmacists all working together. They enable real-time, consensus-based decision-making, often under intense time pressure with very sick patients.
And does having a PERT actually make a measurable difference in outcomes?
It really does. Studies have shown that activating a PERT is associated with tangible benefits, things like lower mortality rates at 30 and 90 days, and also reduced hospital readmissions for PE-related issues. Furthermore, just implementing a PERT program often fundamentally shifts practice patterns within a hospital. It typically looks to an increased use of these newer, safer interventional strategies, even for those intermediate risk patients. It reflects a growing collective confidence in these techniques when you have that expert team making the call.
Okay, that makes perfect sense. Let's pivot then to the actual techniques. How is this done? Let's start with catheter-directed thrombolysis, CDT. This sounds like the chemical approach, but delivered more precisely.
Exactly. It's all about localizing the drug. Instead of systemic infusion, we use specialized catheters that have multiple side holes along their length. Common ones are devices like the Unifuse or the Cragg-McNamara catheters. These are positioned right into the pulmonary artery, ideally near or even within the clot itself. Then we infuse a much lower dose of the thrombolytic drug directly onto the target.
How low are we talking dose-wise compared to the systemic dose?
Typically, it's about one-third, maybe even one-quarter of the standard systemic dose. Often, the total dose of Alteplase, for example, wouldn't exceed 30 milligrams, and it's usually infused slowly over a period of maybe 12 to 24 hours. The brilliance here is maximizing the local drug concentration right where you need it, achieving effective clot lysis, while keeping the levels of the drug circulating in the rest of the body low enough to drastically minimize those systemic bleeding risks.
You mentioned specialized catheters. The source mentions the Bashir catheter. That sounds like it has an interesting mechanism for getting the drug into the clot.
Yes, the Bashir catheter is quite innovative. It's a 7 French system, so relatively small. Once it's positioned in the pulmonary artery, it has a mechanism that allows an expandable basket section at the tip to open up. This basket has multiple microholes for drug infusion. The expansion does a couple of things. It helps anchor the device within the thrombus, but perhaps more importantly, by expanding, it increases the surface area of the clot that's directly exposed to the infused drug. This might enhance drug penetration and overall efficacy.
Okay, interesting. Now here's where the technology seems to really accelerate. Ultrasound-assisted thrombolysis, or USA. This often involves the ecosonic system. What's the thinking behind adding ultrasound waves to the mix?
This is really the aha mechanism that defines a lot of modern CDT approaches. The ecosonic system, which is now from Boston Scientific, combines that low-dose local thrombolysis with pulsed, high-frequency but low-energy ultrasound waves, typically around 2 megahertz. These ultrasound waves generate acoustic pressure right near the catheter tip. It's not powerful enough to physically break the clot apart, but it causes significant mechanical agitation within the clot structure.
How does shaking it up help the drug work better?
Well, the thinking is that this ultrasonic energy helps to unwind and sort of disaggregate the dense mesh of fibrin strands that make up the clot structure. Fibrin is what holds the clot together. By loosening this mesh, you expose more binding sites on the fibrin for the thrombolytic drug to attach to and work on. It effectively enhances drug penetration into the clot and speeds up the whole lysis process. This synergy means you can potentially achieve the same or even better therapeutic results using even lower doses of the drug, and often over dramatically shorter infusion times compared to standard non-ultrasound CDT.
So the goal is less drug, less time, potentially same or better outcome. Let's look at the evidence. What are the key trials that listeners should know about that support this? The Ultima trial seems like a foundational one for USA safety.
Ultima was really crucial, yes. It specifically focused on that intermediate risk patient population, and it clearly demonstrated a significant and rapid improvement in RV function. They measured the RV-LV diameter ratio at just 24 hours in patients treated with USA compared to just standard anticoagulation. But the key finding, arguably, was the safety profile. There was 0 incidents of major bleeding reported in the USA group in that trial. That was a huge confidence booster.
Okay, building on that safety, the Optimize PE trial seems to have pushed the dose even lower and the time shorter.
Exactly. Optimize PE really explored that dose duration relationship. It confirmed that you could get significant improvements in RV function using even lower total thrombolytic doses, as low as 4 to 12 milligrams of Alteplase in some arms, and with much shorter infusion durations, sometimes just 2 to 6 hours. And importantly, this was achieved without sacrificing safety or increasing the bleeding risk. It really validated the principle that lower and shorter is feasible and effective with ultrasound assistance.
This really seems to establish a clear dose safety link then.
Yes.
Because if we look back at the older Seattle 2 trial, which used a higher USA dose, the bleeding rates were quite different, weren't they?
They were. The Seattle 2 trial used a higher total dose, 24 milligrams of Alteplase infused over 12 hours per lung. And while it also showed efficacy in improving RV function, it was associated with a significantly higher incidence of major bleeding, around 10%. So that trial, in retrospect, really validates the current ultra-low dose strategy used in contemporary USA. It starkly highlights that minimizing the total thrombolytic exposure is absolutely paramount for safety. And just to round out the CDT evidence, the Canary trial looked at standard, non-ultrasound CDT and confirmed its longer-term structural benefit, showing a favorable reduction in that RV-LV ratio at 3 months follow-up in intermediate high-risk patients.
Okay, so CDT, especially USAT, offers a way to dissolve the clot with much lower bleeding risk. Let's shift gears now from the chemical approach to the physical one. Mechanical thrombectomy, or MT. That sounds like a big leap in device technology, moving beyond just breaking the clot up.
That's right. While CDT aims to dissolve the clot chemically, MT seeks to physically remove it, either whole or in large fragments. Historically, the simplest form of MT was just fragmentation, using something like a basic pigtail catheter. It's available everywhere, it's low cost, it's quick to deploy.
But it sounds like there's a significant downside risk there.
There is. It's potentially trading one problem for another. When you use a rotating pigtail catheter to braid up a large central clot, you risk causing downstream embolization of smaller fragments. This can effectively convert one large proximal blockage into multiple smaller, more distal obstructions. This can actually increase the overall resistance in the pulmonary circulation, worsen RV afterload, and potentially impair systolic function even more. So while it might restore some initial blood flow past the main clot, it's far from an ideal or definitive solution in many cases.
Okay, so fragmentation is basic. Moving to more advanced powered systems, let's talk about rheolytic thrombectomy. Devices like the angiojet system, how do they work?
The angiojet uses a different principle. It employs high-speed, pressurized sailing jets that exit the catheter tip to macerate or break up the clot. Simultaneously, based on Bernoulli's principle, the flow dynamics create a vacuum effect near the tip, which actively sucks in and removes the clot debris through a separate lumen in the catheter. It's quite effective at debulking clot, and it also has a feature called power pulse, where you can inject a small, local dose of thrombolytic directly into the clot before aspirating, if desired.
And this seems like a really critical safety point listeners need to grasp. The FDA has issued a black box warning specifically for the angiojets used in pulmonary embolism. Why is that?
This is a very significant concern, yes. The black box warning stems directly from the mechanism of action. Those high-velocity fluid jets, while effective at breaking clot, also cause massive destruction of red blood cells right at the catheter tip, that's hemolysis. When red cells break apart, they release their intracellular contents into the bloodstream. This includes high levels of vasoactive substances, particularly adenosine and potassium. This sudden release into the pulmonary circulation can induce severe, sometimes fatal, bradyarrhythmias, slow heart rates, including complete heart block or even a systole, which is cardiac arrest. Other complications like hemoglobinuria, hemoglobin in the urine leading to kidney injury, are also reported. This makes the use of rheolytic thrombectomy for PE a particularly high-risk proposition.
Wow, that sounds like a massive clinical hurdle. Given that warning, do PERTs or interventionalists still consider using devices like angiojet often, or has the field moved on?
It's definitely become much less common in dedicated PE centers that have access to newer technologies. That black box warning really pushed the field towards developing and adopting pure aspiration systems. When the bleeding risk is just too high for any thrombolytics, even low-dose CDT, clinicians need a purely mechanical option that avoids the systemic risks associated with rheolysis. The modern aspiration devices are specifically designed to remove the clot more gently, by suction, aiming to prevent that systemic release of clot breakdown products and cellular debris.
Okay, let's focus on that modern evolution then. Aspiration embolectomy, using powerful suction to pull the clot out. Let's start with the FlowTriever system.
Right, the FlowTriever system, which is from Inari Medical, is really designed for dealing with large clot volumes. It utilizes large lumen aspiration catheters that come in sizes up to 24 French, which is quite big, allowing them to suck out substantial amounts of thromboembolic material. The suction is generated manually using a large 60 milliliter syringe connected to the catheter. And importantly, it also includes optional clot retriever discs. These are self-expanding nitinol mesh discs deployed through the catheter that can help engage and pull back more organized or adherent clot if simple aspiration isn't enough, which happens in maybe about a quarter of cases.
And one of the big concerns with any major intervention, especially when patients are often on blood thinners like heparin, is blood loss. How does FlowTriever address that?
That's where their FlowSaver system comes in, which is quite clever. It's essentially an external blood filtration and reinfusion system. The blood and clot mixture that's aspirated out is passed through a 40-micron filter. The filtered blood, free of clot debris, can then be returned directly to the patient. This significantly limits the overall net blood loss during the procedure, which is really critical, especially in hemodynamically unstable patients where every drop of blood counts.
And the clinical data for FlowTriever seems to have been quite strong, building from early studies like FLAIR up to the really impressive results from the FLAME study in high-risk patients. You touched on those outcomes earlier. Can you remind us what stood out?
Yes, the FLAME study, although it wasn't a randomized trial, specifically focused on those very sick, high-risk, unstable PE patients. It compared outcomes in patients treated with FlowTriever versus a context arm, which included similar patients treated with other therapies like systemic thrombolysis or just anticoagulation alone, based on historical data and matched controls. The results were striking. The composite primary endpoint, which included things like death, clinical deterioration requiring escalation of care, major bleeding, and need for bailout procedures, occurred in only 17% of the FlowTriever patients, compared to almost 64% in the context arm. And the difference in hospital mortality was particularly dramatic, just 1.9% with FlowTriever versus nearly 30% in the context arm. Now, you have to interpret non-randomized data cautiously, but those results have really shifted the conversation about using upfront interventional therapy, specifically aspiration, for the sickest PE patients.
Okay, so FlowTriever sounds like the powerhouse, focused on big clots, large volume removal, and preserving blood. How does the Indigo system from Penumbra contrast with that? It seems maybe more focused on precision and getting further out.
That's a good way to put it. The Indigo system generally uses smaller, more flexible aspiration catheters, typically in the 12 or 16 French range. This increased flexibility is a key advantage, as it potentially allows the catheter to navigate further out into the more tortuous and distal branches of the pulmonary arteries, accessing clots that might be harder to reach with the larger, stiffer systems like FlowTriever. Instead of manual syringe suction, Indigo uses continuous vacuum suction provided by an external pump.
And their key differentiating technology is the computer-aided system called Lightning, is that right? How did that work?
Oh, yes. The Lightning system is integrated into their 12 French catheter setup. It uses a proprietary computer algorithm connected to sensors near the catheter tip. This algorithm is designed to continuously monitor what's being aspirated and can supposedly differentiate between clot material and free-flowing blood in real time. When it senses that mostly blood is being aspirated rather than clot, it can automatically open and close a valve intermittently to minimize further blood loss. The aim is to keep the total procedural blood loss significantly reduced, typically reported as being under 400 milliliters, which is another major advantage for maintaining hemodynamic stability during the procedure.
So maybe FlowTriever for the big central clot burden and Indigo potentially for more distal clots, or where minimizing every bit of blood loss is paramount thanks to Lightning. What does the evidence show for Indigo's effectiveness?
The main trial for Indigo in PE is the Extract PE study. This is a prospective single-arm trial looking at safety and efficacy, primarily in the intermediate-risk PE population. It demonstrated significant hemodynamic improvement, specifically showing about a 27% reduction in the RV/LV ratio from baseline to 48 hours post-procedure. And importantly, it showed a very favorable safety profile with a major bleeding rate of only 1.7%. So this trial really helped solidify large volume aspiration embolectomy, whether with Indigo or FlowTriever, as a powerful and importantly low bleeding risk alternative or adjunct to thrombolysis for select PE patients.
Okay, it seems like aspiration is really coming into its own. Before we move to the future, we should touch on prevention and longer-term issues, specifically inferior vena cava filters, IVC filters.
Right. While intervention tackles the clot already in the lungs, IVC filters are about prevention, specifically preventing new clots from reaching the lungs.
These are mechanical devices, like little cages placed in the IVC, the big vein bringing blood back from the legs and pelvis. The idea is to trap clots traveling up from DVTs, right? Who actually gets these filters? It sounds like they shouldn't be used routinely.
Definitely not routinely. They are strictly reserved for a very select group of high-risk patients. The guidelines really point to two main indications. First, patients who have an acute DVT or PE, but have an absolute contraindication to taking anticoagulant therapy. They simply cannot take blood thinners, maybe due to active bleeding or extremely high bleeding risk. Second, those rare patients who unfortunately suffer a recurrent PE despite being on adequate doses of anticoagulation. It's generally considered a Class III recommendation, meaning it should be considered or maybe reasonable, but only in these specific limited scenarios.
And there's a critical difference between the types of filters available, isn't there? Permanent versus ones that are supposed to be taken out.
Indeed, that's a crucial distinction. Retrievable filters are designed for temporary protection during that period of high risk when anticoagulation isn't possible. The intention is always to remove them promptly once that risk period is over or anticoagulation can be safely started. Permanent filters, on the other hand, stay in for life, and they carry a significant long-term risk of complications themselves. These can include the filter fracturing, migrating out of position, perforating the wall of the vena cava, or, most commonly, the filter itself becoming a site for new clot formation leading to caval thrombosis, which can be a major problem.
That sounds like a serious long-term trade-off. Which brings us to a fascinating newer technology you mentioned, bioconvertible filters.
Yes, bioconvertible filters, like the Sentry device that's available, are quite innovative. They are designed to provide filtration during the high-risk period, similar to a retrievable filter. But then, over time, parts of the filter are designed to naturally degrade or dissolve, while the remaining frame integrates safely into the caval wall. This offers a potential way to get the short-term benefit of filtration without needing a second procedure to remove the filter, and potentially avoiding the long-term complications associated with permanent filters or retrievable filters that get left in too long, which unfortunately happens quite often.
But the overall clinical evidence around IVC filters seems really controversial. This is a point listeners probably need to understand clearly. It sounds like short-term benefits might clash with long-term risks.
That is absolutely the core of the ongoing IVC filter debate. It's complex. The original landmark trial, PREPIC, looked at patients with DVT, but not necessarily PE, who were getting anticoagulation. It did show that adding an IVC filter reduced the short-term incidence of developing a PE over the first 12 days. So the filter did its job initially. However, when those same patients were followed up long-term, that initial benefit in preventing PE was completely offset by a significantly increased long-term risk of developing deep vein thrombosis, DVT.
So wait, the filter stops the clot from reaching the lungs now, but it seems to create a risk of clots forming around the filter in the IDC itself later on, leading to chronic leg problems.
Precisely. You're potentially trading an acute, possibly fatal event, PE, for a chronic, often debilitating condition like post-thrombotic syndrome, PTS, which results from chronic DVT or obstruction of the vena cava. It causes leg swelling, pain, skin changes, and can be very difficult to manage. And then the PREPIC-2 trial further complicated things. This trial looked specifically at patients with acute symptomatic PE who were able to receive anticoagulation. Adding an IVC filter on top of anticoagulation in these patients showed absolutely no reduction in PE recurrence at 3 months.
So that strongly suggests that if a patient can be effectively anticoagulated, the filter probably offers little or no additional benefit in preventing recurrent PE and only adds potential long-term harm.
That's the general interpretation, yes. It really underscores that the decision to place a filter must be intensely individualized. There might be some nuances. For example, some registry data suggests that in very specific populations, like perhaps DVT patients who also have active cancer, filters might improve PE-free survival. But conversely, in trauma patients where filters are sometimes placed prophylactically, while they might reduce in-hospital mortality from PE, some studies suggest they are associated with an increased overall risk of both PE and DVT down the road. It really demands a careful weighing of the individual patient's immediate risk of a fatal PE versus their risk of bleeding with anticoagulation and the potential long-term complications of the filter itself. It's not a straightforward decision.
Okay, that clarifies the filter situation significantly. Let's look ahead then. We've established that these catheter-based techniques, both CDT and MT, are highly promising, definitely safer than systemic lysis in terms of bleeding. What are the remaining hurdles for them to potentially move from being effective alternatives to becoming the standard of care, maybe even first line, for certain PE patients? We know timing is critical.
Timing is absolutely paramount, especially for the sickest patients. The data consistently shows better outcomes, both in terms of efficacy and safety, when intervention is initiated early, ideally within the first 24 to 48 hours of diagnosis for intermediate risk. For high-risk patients, that window is incredibly narrow. Current protocols often aim to initiate some form of reperfusion therapy within 60 minutes of diagnosis, or maybe a maximum of 90 minutes if the patient needs to be transferred to a specialized center capable of intervention. Every minute counts when the RV is failing.
But despite the really impressive results we're seeing from some of those single-arm trials like Ultima for USIT or Extract PE for Indigo or Flame for FlowTriever, the key thing holding back a major shift in guidelines seems to be the need for more high-quality randomized controlled evidence, right?
That is absolutely the bottleneck right now. As promising as these therapies are, current international guidelines still do not recommend any percutaneous treatment as the routine first choice for any specific PE risk category. And the reason is precisely that lack of large-scale prospective randomized trials that directly compare these newer interventional approaches head-to-head against the current standards, which are usually anticoagulation alone for intermediate risk or systemic thrombolysis for high risk. We especially need trials that look not just at short-term hemodynamics or bleeding rates, but also at longer-term functional outcomes, quality of life, and mortality. The future of PE guidelines really hinges on the results of the big trials that are ongoing right now.
Okay, so let's highlight those key trials for listeners. These are the ones that everyone in the field is watching closely as the results start to emerge. Focusing first on catheter-directed thrombolysis, particularly USAD. Which trials are pivotal?
There are two major randomized trials targeting that crucial intermediate high-risk population, HiPiTho and PROG-26. Both are essentially comparing US8, using the ecosonic system, plus standard heparin anticoagulation against just standard anticoagulation alone. These are large, well-powered trials, and they're primarily focused on short-term outcomes specifically, reducing a composite endpoint, usually including things like all-cause death, hemodynamic decompensation requiring rescue therapy, or confirmed PE recurrence, typically within the first 7 days. If these trials show that add-in US8 provides a significant short-term benefit in preventing clinical worsening without increasing major bleeding or overall mortality, that would be a massive step towards validating USAT as a preferred upfront strategy for these ticking time bomb patients.
Okay, so those are looking at immediate critical outcomes. But you mentioned long-term function. What about proving that intervention actually helps patients feel better and do more in the long run? Which trial is tackling that?
That's the specific mandate of the PE TRACT trial. This is another large, important phase 3 randomized trial, aiming for about 500 patients. It's comparing early intervention using either CDT or mechanical thrombectomy, the choice is often left to the site operator, against just standard anticoagulation. And its primary endpoints are really focused on that longer-term functional recovery. They're measuring things objectively like peak oxygen consumption during exercise testing, a measure of cardiorespiratory fitness, and also patient-reported symptoms using the New York Heart Association, NYHA functional class, assessed at 3 months and 12 months. If PE TRACT shows that intervening early leads to better long-term functional capacity and fewer chronic symptoms compared to just anticoagulation, that provides a very powerful clinical argument beyond just short-term hemodynamics.
Makes sense. And finally, what about the head-to-head comparisons? We have CD-TUST, and we have these sophisticated aspiration MT devices like FlowTriever and Indigo. Are there trials directly comparing these interventional approaches against each other?
Yes, and those are absolutely crucial for guiding practice within the interventional community itself. The Peerless program of studies is designed to do just that. The main Peerless trial is randomizing intermediate high-risk PE patients directly to receive either aspiration embolectomy using the FlowTriever system or standard catheter-directed thrombolysis. And very importantly, Peerless includes a specific cohort of patients who have absolute contraindications to any thrombolytics. This will provide invaluable data on the effectiveness of purely mechanical aspiration in a group where treatment choices are currently extremely limited. Furthermore, there's Peerless 2, which is planned to be even larger, maybe 1,200 intermediate-risk patients randomized to upfront FlowTriever versus standard anticoagulation alone, looking at 30-day outcomes like decompensation and hospital readmission. The results from the Peerless program will be absolutely pivotal in establishing the relative roles and potentially the preferred approach between modern aspiration thrombectomy and catheter-directed lysis.
Okay, so a huge amount of high-quality evidence is hopefully just around the corner. This accumulation really points towards that provocative concept the authors introduced, percutaneous primary pulmonary intervention. It really does feel like we might be on the cusp of a historic shift in how we treat PE, doesn't it?
I think we are seeing a very powerful historical analogy playing out here. If you look back at how the treatment of major heart attacks, ST elevation, myocardial infarction, or STEMI evolved over the last few decades, the first effective reperfusion strategy was systemic thrombolysis, clot busters given intravenously. It worked, it saved lives compared to nothing, but it carried that significant bleeding risk, including stroke. Then came percutaneous coronary intervention, PCI, or angioplasty and stenting. Once trials definitively proved that PCI could open the blocked coronary artery faster, more reliably, and much more safely than systemic thrombolysis, the standard of care shifted globally. Primary PCI became the default first-line strategy wherever it was available.
So the aspiration is that for PE, catheter-based intervention could become as routine, as safe, and as readily available as primary PCI is now for a heart attack.
That's exactly the vision. As the safety profiles of these percutaneous PE devices continue to improve, especially with innovations like the computer-aided suction modulation in Indigo or the blood filtration with FlowTriever, and as this robust randomized trial data starts to accrue, It seems highly likely, I think, that minimally invasive endovascular approaches will become the preferred default first-line strategy for certain well-defined subsets of PE patients. It seems like the only way to comprehensively overcome the inherent limitations and that sort of hidden bleeding burden that always comes with systemic thrombolysis. The goal is to establish a new, safer gold standard for pulmonary artery reperfusion. The speed, the targeting ability, and the improving safety of these modern devices really make that outcome feel almost inevitable in the coming years.
Well, that was an incredibly comprehensive deep dive into the rapidly evolving world of PE management. We've really mapped that crucial journey away from the high-risk trade-off of systemic thrombolysis toward these much more targeted, localized approaches like low-dose CDT and especially ultrasound-assisted thrombolysis. And the technological loops of mechanical thrombectomy, particularly with these large-bore aspiration systems like FlowTriever and Indigo, are just fundamentally reshaping the possibilities for rapid, safe clot removal. And underpinning all of this is the absolute critical role of the pulmonary embolism response teams, the PERTs, in ensuring that rapid assessment and sophisticated patient selection happens effectively in these high-stakes situations.
And that really leads us to a final provocative thought for you, our listener, to consider. Given these strong trends we've discussed, the significant industry investment pouring into developing these catheter-based therapies, and the proven benefits of having organized PERT programs, how might the increasing availability of specialized PE treatment centers actually change the way hospitals organize and staff their emergency cardiac and vascular services over, say, the next 5 years? Especially if these large, ongoing randomized trials confirm the safety and the long-term functional efficacy that we are all anticipating, it could really reshape acute care pathways.
Something to definitely think about. Thank you for watching The Funnel Effect.